Hello, and welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and our program is part of the Digital Anatomic Pathology Academy. The Digital Anatomic Pathology Academy is a joint venture with Digital Pathology Association and Path Presenter, a wonderful platform to learn and share pathology information. Our case today comes from the realm of bone and soft tissue pathology and is a young person, about 11 years old, who's developed some pain in his lower extremity and has a little bit of a change in gait that makes it very difficult and uncomfortable to walk. Radiographic analysis is of course, going to be important with this, but there are also some interesting factors in the history. So the patient has a history of Osgood-Schlatters disease, which was diagnosed a few years previously. He's not been previously immunized, and he's fairly active. In addition, in his social environment, he uses a number of different herbal remedies and supplements that raise an interesting possibility of other considerations. However, as we get the radiographs, we discover that there is an irregular pattern, both variable density in his tibia proximally, as you can see here. In addition, there seems to be a soft tissue component to this that's somewhat rim enhancing. And the pattern within the bone shows a very erratic and sort of moth-eaten appearance on this T1 sagittal section. In addition, on the further lesions, we can see that the stir lesion shows that there's some fluid accumulation with this, and here in the soft tissue lighting up with that. And you can also see some accentuation of the periosteum on the axial images as well, indicating that this is a lesion that has elevated the periosteum as well as penetrating it, forming that soft tissue mass. So as we think about permeative bone lesions in kids that could present in this sort of a manner, fairly acutely with pain, there's essentially a big five. Lymphomas, of course, can do this, osteosarcomas, Ewing sarcomas, Langerhans cell lesions, and infectious lesions could all give you this sort of a differential consideration in a pediatric patient. So for pretty much all of those, a biopsy is going to be necessary. And of course, the surgeons want to consider how and where to approach the biopsy with such a lesion because they may have to operate in follow-up, and they don't want to contaminate the wrong sort of field. So in this case, they opted to go after the soft tissue component, and we received some samples that looks like this. As you see, a lot of bloody material, but then areas of bluish tissue here. And it's fairly homogeneously blue as we come into higher magnification. You can see there's a fair bit of clearing in the cytoplasm, which, as we come down into highest magnification here, represents some slight vacuolization of the cytoplasm. And I think you can see the nuclear features here, even though this was only scanned at 20x, are essentially devoid of any prominent nucleoli. We don't see a high degree of pleomorphism. We don't see this isn't an inflammatory process. We're not looking at abscess contents. So we've helped them right there. And on the frozen section evaluation, we could certainly tell them we have diagnostic tissue. It looks like a small blue cell neoplasm. So we're really looking at the differential between lymphoma, small cell osteosarcoma, and Ewing sarcoma, pretty much as in terms of the differential considerations. So that leads us to go after some immunohistochemistries, which may be pertinent to narrowing that differential. CD45 was done, which was negative, and CD99 was performed, which was positive, which puts us into the category of Ewing sarcoma, as well as a few other sarcomas that can be positive with this. As you see here, very nice strongly membranous and slight cytoplasmic positivity with the CD99 marker in this case. Though CD99 is not a specific marker, certainly can be seen in a variety of small cell neoplasms, sarcomas, and so forth, including synovial sarcoma, Ewing's, and some other less frequently encountered sarcomas. So you do want to be thinking about the more specific diagnostic tools that we have, which would include FISH testing to look for the rearrangement of 1122 or 1123 that can be seen with Ewing's. It's also of note that this pattern and that sort of staining could be seen in a number of other possibilities. I want to comment here about the clearing on the cytoplasm. This led to use of the PAS stain for evaluation. This is not from our particular patient case, but I think nicely illustrates what's going on in terms of the permeative pattern of growth. Here you see this small cell neoplasm, and here it's stained with PAS to highlight the glycogen production within these cells. But as you can see here, it just very extensively permeates the marrow spaces and extends out into the periosteum or towards the periosteum, raising the periosteum and producing that elevated moth-eaten appearance. So this permeative pattern leads to some bony resorption in a variable way. The expansion in the periosteum enhances that appearance, and you end up with sometimes a sort of a starburst type of pattern, although that's more characteristic of periosteal elevation with osteosarcoma than with Ewing sarcoma, which tends to give you more of a fusiform and longitudinal spread rather than the other. So we're thinking that this is most likely Ewing sarcoma, and in fact, our fusion gene analysis did find that this patient had a fusion with EWSR1 and FLY1, which represents a T1122 translocation. This is the most frequently encountered fusion gene in Ewing sarcoma, though some other fusion partners with the EWSR1 gene have been identified. So immunohistochemistry, as we've indicated, CD99 is very helpful. FLY1, less readily available, but can also be positive, as well as NKX 2.2, ERG, and so forth. The things that we would not be considering here, would not expect to find, would be CD45, MyoD1, WT1, NUT1, which can occasionally have a small blue cell appearance, and certainly any neuroendocrine markers would be also expected to be negative. Now, note there are some rare epithelioid versions of Ewing sarcoma that may be cytokeratin positive, and so that can be slightly misleading, and need to be aware of that potential pitfall. In contrast to that case where I showed you resection of a large long bone with viable tumor remaining, now we tend to approach these tumors with neoadjuvant treatment, and that has significantly enhanced our survival, which is now 70% or more. And the main prognostic feature is the presence of metastatic disease. Now, our patient presented with a fairly short symptomatic history and was not found to have any evidence of metastases, and so underwent neoadjuvant treatment followed by surgery, and then based on our findings then would have potentially received additional treatment following that. Here, just to give you an idea of what the resection specimen looks like, you can see here the attached soft tissue, our residual bone. And as you can see, even at low power here, we do have some islands of sort of bluish tissue maybe up in the periosteum, certainly down here, over here as well. And as we take a look at this, you can experience with me maybe some of the angst that we sometimes feel. Is this inflammation? Is this neoplasm? Well, you notice here that we do have this nice delicate vacuolization of the cytoplasm of many of these cells. So they don't look quite like typical inflammatory cells or histiocytes. They very much look like the neoplastic cells, although they're here scattered and somewhat diffusely associated with neovascularization. Here's a few more of them here. Look maybe a little bit more convincing and concerning for tumor. And even as we look here towards the soft tissue interface, I think you can appreciate here there's just a little bit too busy a cellularity here. And again, we have some of these cells with this fine vacuolization. Well, we didn't repeat the FISH testing here, but we did do the CD99 stain to demonstrate that, in fact, as you'll see here, these cells do light up with CD99 here in that more prevalent area. And even as we come over here towards the, let's make sure we get to the right area, towards the area where we're bulging into the soft tissue, you can see that we have some little clusters of cells here that are clearly staining with that nice membranous pattern with CD99. So this is the resection with a very good response, the massive shrinkage of the soft tissue mass, but still some residual tumor present consistent with Ewing sarcoma. So our final diagnosis on this case is Ewing sarcoma. I would just put in the comments here on this case that there are a number of other tumors that can have EWSR fusion and need to be considered in the differential that include a variety of types of neoplasm. So I hope you enjoyed this case, and will hit that like button and subscribe. Certainly welcome your comments, suggestions for future topics to cover. And so until next time, thanks so much for joining me.